UCI Senior.
Thank you. And Dr. Campbell.
Hey everyone, my name is Sarah Campbell. I'm a family nurse practitioner. I teach as an assistant clinical professor in our School of Nursing, our family nurse practitioner program, and I also see patients on site at UC Irvine on campus. Thank you for being here today.
Wonderful. Thank you to our hub team. I see some people here from Pennsylvania, St. Luke's University, from Guam. Welcome, Dolores. From Oroville, California, and from right here in Orange County. So again, thank you all for introducing yourselves. I see some more coming in. Thank you all for joining, and we'll go ahead and move on into our didactic. Dr. Gurvich, go ahead and take it away. Today's session is going to be focusing on the pharmaceutical treatment of dementia.
So you're going to advance the slides, right? Okay, next slide. So we're going to talk about a couple of things. We're going to talk about the issue of polypharmacy in patients with dementia and how to avoid it. We're going to talk about a little bit on geriatric prescribing and appropriate medication use. We're going to talk a little bit about the Beers criteria as it relates to the cognitively impaired, and talk a little bit about the pharmacologic options we have at managing cognitive decline. Next slide. So I don't know if you've been to some of my talks, but this is a slide I show. This is what we typically see in our assessment program at UCI. Patients with some kind of cognitive impairment show up with all of their meds in hand, and this patient brought in 3 full bags worth of medications. The slide is blurry for a reason. I think there's a lot of confusion that goes on with patients who are cognitively impaired who can't figure out what to take when. Caregivers are often confused, and physicians don't often have time to go through this whole mess to figure out what is needed and what can be thrown away. Next slide. This is what we found in a patient's pantry when we visited his home. He was a low-income kind of a facility, and he was actually complaining to us about not having enough money for food. So this is what we found when we opened up his pantry. So clearly there's a lot of herbal products here, lots of duplication. But in terms of cognitive impairment, a lot of these herbs actually have, belladonna-related products, which can contribute to cognitive impairment. Some herbs that are promoted to improve cognitive function work very similarly to the prescription medications we give. So sometimes that creates additive kind of therapy and more side effects. And some medications, like herbs like ginkgo, for example, can cause bruising and potential for bleeding, again, producing a lot of unwanted adverse reactions and side effects. If you look at the bottom of the screen here, you've got some tinctures here, and tinctures are known for their alcohol content. So when we saw how many there were, we figured out the dosing for each one. We figured out that if this particular patient took every single tincture on a daily basis, he would be getting the equivalent of about 2 to 3 alcoholic beverages a day, which again, if you're dealing with a cognitively impaired person, that could be a substantial problem. Next slide. So when we talk about geriatrics in general and kind of geriatric syndromes, we often see these things: memory loss, confusion, depression, dizziness, drowsiness, and so forth. Memory loss and confusion could be a medical problem that needs to be worked up and diagnosed and treated, but it could also be a drug side effect. And so when you see these patients with cognitive impairment, the first place you want to look at is their medication list to see if any of them can contribute to this problem. And here's a quote from a very smart physician who said that any symptom in an elderly patient should be considered a drug side effect until proven otherwise. Next slide. So how do we look for polypharmacy in the cognitively impaired? So obviously 5 or more medications is a potential risk. So whenever you see a list of 5 meds on the medication list, please review them and make sure that each of them needs to be there. I often see patients on significantly more meds. And again, you have to go through each one and figure out if the dose is right, if the indication is right, or if the medication needs to be there. Make sure that every drug has an appropriate indication, and if you can't figure out why it's being used, get rid of it. When you have long lists, like older adults often have, you see duplications in therapy, and so sometimes that can be cleaned up by looking at that. If you've got a lot of CNS active medications on the list, remember that CNS kinds of side effects like confusion, sedation, dizziness can be cumulative. So the fewer meds on the list with CNS component, the better. You also want to go over the over-the-counter meds that patients are taking, and this is often not done because patients either don't tell their providers that they're on them or providers forget to ask. But here we've got a table of, pictures of a bunch of different over-the-counter products commonly used by patients and older adults in particular that actually have high-risk medications that are listed on the Beers criteria. So there are lots of combination products out there. So when patients tell you they take Tylenol, make sure it's not Tylenol PM and it's just regular Tylenol. Because PM obviously is an additional diphenhydramine. So go over the over-the-counter products that patients take. Carefully review how much alcohol they drink. If they say they have 1 or 2 glasses, find out how big those glasses are. Sometimes, you think they're small 6-ounce glasses, but they could be 12-ounce tumblers. So always get an idea of how big the glasses of wine or beer that they have. And always ask about cannabis. Remember, this is a generation of patients who grew up in the 60s, and they may not consider cannabis a real drug. So when you ask a general question about drug use, they'll say, no, I'm not using anything. But when you ask specifically about cannabis, you'll be surprised at how many patients actually report using something, either topical or PO, and even CBD oil in cream form is absorbed. If there's time at the end of the talk, I'll tell you a little personal story that I discovered taking care of my mother. But it is absorbed, and it can produce systemic effects. You obviously want to focus on high-risk medications, and we're going to talk about them in a few slides, which are on the Beers criteria. But you also want to look at all the non-high-risk meds for their CNS component to make sure that you're not getting additive effects. In terms of dosing, you're dealing with frail older patients, so you want to start with a lower dose, titrate more slowly, but you may end up having to go to a maximum dose to achieve therapeutic effect. Next slide. So going to the Beers criteria, this is last updated in 2019, and we're actually due for an update sometime this year, I think. So this is a list of all the anticholinergic medications, which in addition to causing constipation, dry mouth, and
Eileen, is there any other
can
stuff
also
that
cause
you're doing
confusion in older
that
adults.
someone
And
else?
so
Yeah, that's what I'm gonna start doing.
can people mute themselves maybe?
Pretty much CMR. I'm gonna give it.
Anyway, the anticholinergic effects can cause cognitive impairment, confusion, and so you want to screen patients for the drugs on this list. And it's a pretty extensive list. You've got some over-the-counter medicines here that are on the Beers criteria. You've got a bunch of antidepressants, but particularly like paroxetine is not a tricyclic. It's an SSRI with some anticholinergic potential, so that's something to keep in mind. All urinary antispasmodics can cause cognition problems, even the newer ones, which are supposed to be better tolerated. Promethazine is what's in Phenergan, so we often don't think of it as an anticholinergic, but it does have those properties. Antipsychotics are on this list. Olanzapine actually is an atypical antipsychotic with significant anticholinergic profile. And obviously, belladonna-related products, some muscle relaxants, and some GI products that are primarily used for IBS with the predominant symptom of diarrhea. So go through the med list, look for those anticholinergic drugs, and try to get rid of them. Next slide. So again, going through the Beers criteria, here you're dealing with, again, muscle relaxants, benzodiazepines, the Z drugs like Ambien, Lunesta, and Sonata, and some of the antipsychotic agents, which we actually end up using sometimes in patients who have severe agitation, and I'll talk about that in a minute. But definitely you want to get rid of benzos, the Z drugs if you can, and some muscle relaxants. Next slide. Obviously, when a patient has cognitive impairment or active delirium, you want to get rid of everything anticholinergic. So tricyclics, anticholinergic drugs that were listed on the previous slide, sedative hypnotics, some antipsychotics have have anticholinergic profile. And then with H2 blockers, again, if somebody is in acute delirium, you don't want to use them because they can exacerbate it. But if you've got a chronically demented patient not in delirium, you can go ahead and use them because they're considered to be safer than using PPIs long term. Next slide. A product like Nuedexta, which is a combination of dextromethorphan and quinidine, should really not be used for behavioral symptoms in dementia, except when you've got pseudobulbar affect going on. And drugs that have been removed from the Beers list, this is aripiprazole or Abilify. It's no longer the drug of choice in Parkinson's-induced psychosis. What they really want you to use is pimavanserin because that's got an FDA indication for it. The trouble with pimavanserin is it's extremely expensive, and most Medicare Part D plans just don't cover it. So we run into trouble with getting it approved for patients or who want to use it or providers who want to prescribe it. Next slide. Some drug interactions on the Beers criteria. Again, you want to avoid drug cocktails is sort of the general rule. So when you're dealing with opioids, seizure meds, antidepressants, antipsychotic, the Z drugs, you're really increasing the risk of cognitive impairment, falls, fractures, and potential for overdose. So you want to avoid combinations of 3 or more. And remember, if you're using one anticholinergic, you may have some anticholinergic activity. If you're using more than one, you get what's called an anticholinergic load, so you get more of an anticholinergic effect, and so that can produce more cognitive decline. Next slide. So let's talk a little bit about managing depression, anxiety, and agitation, which are common things you see in patients with cognitive impairment. So let's take a little bit a closer look at SSRI. So this is a pretty extensive table for you to kind of look at after this talk, but these are common SSRIs that are used. The ones we really like using in demented patients are things like escitalopram. It's a very potent medication. You don't have to give a lot of it, and it works well. It's also got fewer drug-drug interactions compared to some of the others. Citalopram is also not a bad choice. The biggest issue with it is QT prolongation at higher doses. And if you look at this dosing column, this particularly addresses an older adult. So the starting doses are going to be lower than an average starting dose in a younger patient. So that's why I think this table is particularly useful. You generally want to stay away from fluoxetine, which tends to be more activating, longer half-life, and can produce a little bit more anxiety and agitation in an older demented patient. And paroxetine, again, you want to stay away from because of its mild anticholinergic profile. So in those who are cognitively impaired, probably not an ideal drug. Zoloft has a lot of diarrhea you see especially in the beginning. And remember, some of the cholinesterase inhibitors we're going to use for dementia also have GI side effects similar to this. So you want to make sure there aren't any additive effects and which produce weight loss potentially. Next slide. So in terms of SNRIs, my favorite is probably duloxetine because you can use it for anxiety, you can use it for depression, and you can also use it for pain. So that's a good kind of combination of symptoms to use this for. You do want to avoid it in hepatic impairment, but the liver toxicity really occurs pretty rarely. It can cause an increase in blood pressure, especially at higher doses. But again, not a terribly common side effect. Venlafaxine is also a nice alternative if duloxetine is not covered or is poorly tolerated for whatever reason. I don't know that there's much of a benefit from using Pristiq or this last one, Fedzima, which I have not seen used yet in our clinic. But the duloxetine and venlafaxine we use pretty liberally in our patients. Again, the key here is doses. The doses are very, very small to start with and with a slower titration schedule. Next slide. In terms of miscellaneous agents, we use a lot of mirtazapine because it also is helpful with sleep at lower doses. So if somebody's depressed and having trouble settling down for the night, maybe giving them 7.5 milligrams of mirtazapine or even 3.75 in your very frail, small patients could be helpful. Bupropion may not be tolerated well in dementia patients because it's a little bit more activating and can cause some anxiety, insomnia, and in demented patients, agitation. Trintellix, it seems to be tolerated well in the older population, but it's at this point brand only, and so most Medicare Part D plans just don't cover it. Next slide. So when you're choosing an antidepressant, you really want to try to sort of map the drug to the patient's symptoms and drug side effects to the patient's symptoms. Some of the side effects to keep in mind that some of these drugs will cause nausea, vomiting, and diarrhea, especially in the beginning. And remember, keeping in mind that cholinesterase inhibitors kind of have the same side effect profile, so making sure that there's not additive effect from that. Some antidepressants will cause restlessness, nervousness, and sexual dysfunction, which may be a problem in some of your demented patients. Dizziness and fall risk is always an issue with older adults, and especially with those with dementia. So that's another reason to start with a lower dose of an antidepressant and titrate up very slowly with close monitoring. Hypertension can be a problem primarily with SNRIs only, and with Effexor at higher doses. And then you want to keep an eye on, bleed risk and other medications like NSAIDs, aspirin, Plavix, and anticoagulants. Hyponatremia is a consideration in older patients. Usually I see it with higher doses of antidepressants. And then it's usually pretty mild, so you actually don't have to do anything with it. You just kind of keep an eye on it, make sure sodium doesn't drop too much. And then one of the reasons to try to avoid cocktails is because, patients do become at risk for serotonin syndrome. So you want to minimize doses of these serotonergic drugs and maybe minimize drug combinations. When you're stopping one and starting another, it's always recommended to cross taper and doing it slowly to avoid any adverse reactions. Next slide. So medications used for anxiety, which are common, anxiety obviously and agitation is common in patients with dementia. So we've got 4 drugs here that are commonly used. The top 3 you really don't want to use because they're all benzodiazepines and actually can contribute to cognitive decline. The one that's a really big no-no is clonazepam. It's got a significant half-life, 40 hours. Lorazepam, if you have to use a benzo, and I don't like using them, but if I have to use them, lorazepam is probably the one you would use. Again, starting with a very small dose of 0.25 milligrams and titrating up slowly. Again, keeping in mind that fall risk is a huge problem, confusion is a problem, and further cognitive decline is also a problem. But then, you're always looking at it from a risk-benefit kind of a scenario, and in selected patients, lorazepam can be used occasionally. I don't like alprazolam or Xanax. I think it's really hard to get a patient off of it once they're on it. Again, half-life is not terribly long, but the addiction potential is really huge, so we generally don't use Xanax. Buspar is a nice alternative when you shouldn't be using a benzo. It's a chronic med, just you would use it the same way you'd use an SSRI. The starting dose is low, 5 milligrams at bedtime, and titrate up as needed. It can be given multiple times a day. And, it is effective for generalized anxiety and can be useful in patients with cognitive decline. Next slide. So what is Buspar? It's basically a serotonin agonist, very similar to the SSRIs we have. It does take 3 to 4 weeks to see benefit. There are case reports of good efficacy in older adults with dementia. There aren't any randomized controlled trials, but there are good case reports that point to Buspar as possibly an option. And the reason it's a better option is because, you don't get as much respiratory depression and less likely to cause cognitive impairment or falls, and fewer drug interactions with other medications compared to a benzo. Next slide. So management of behavioral symptoms like agitation will sometimes require you to use an antipsychotic. And this table kind of shows the common ones we use and the doses at which we're going to use them. So these are really OBRA-guided, very tiny doses. These are not antipsychotic doses that you would use in a schizophrenic patient, for example. These are baby doses. And the max dose is also a low dose. So obviously, antipsychotics have a black box warning for an increased risk of stroke or death when used in demented patients. So when we do use them, we really want to be careful and selective about when to use them. And you really want to use them for behaviors that pose a danger to either the patient or to others. So for example, if the patient is completely refusing care and refusing, for example, to take medications, or if they're striking out at the caregiver, if they're biting them, if they're spitting at them, if they're agitated to a point where it's interfering with overall care for the patient, or if they're having psychotic features, you could go ahead and use these antipsychotics, but again, starting at low doses and titrating very, very slowly to a low dose, max dose. You also want to monitor for efficacy because these behaviors don't often disappear when you use an antipsychotic. So you want to make sure that if you're giving it, the behavior that you're treating actually goes away. So this therapy has to be very behavior targeted, identifying particular behaviors for which these drugs are given and seeing if there's a benefit from this. So the first four are kind of your atypical antipsychotics. Quetiapine is the most sedating one, so if they have trouble at night with difficulty sleeping and these agitated behaviors, you might start with that. Risperidone, they're all kind of low in EPS overall, but with risperidone, it's very much dose related. So as you go up the dosing ladder, you might see a little more EPS compared to the others. Zyprexa is probably the most anticholinergic of all of these drugs, so I don't like to use it in patients with dementia, but risperidone and quetiapine we use quite a lot. Abilify is a little bit more expensive, so we generally don't use it. It's poorly covered by Medicare Part D plans. And pimavanserin, we've started using it in a few patients. This has a completely different mechanism of action. It's primarily a serotonin receptor modulator as opposed to being a dopamine antagonist and anticholinergic and antihistaminic. So the side effect profile is significantly better with pimavanserin than with the other antipsychotics. But again, not very well covered by insurance and extremely expensive. And at this point, we don't get a lot of utility of it for that reason. Next slide. So let's talk a little bit about medications that are used to stabilize the cognitive decline in our patients. Next slide. So overall, these sort of traditional medications that we use, like cholinesterase inhibitors and amantine, what they really do is just delay the progression of the disease a little bit. And there's some evidence that if you start treatment early, you might get more of a delay than if you started later in the game. So when the patients first start having symptoms, you might consider starting one of these agents to see if you can delay the progression of the disease. Next slide. So for cholinesterase inhibitors, we have three options: donepezil, rivastigmine, and galantamine. They're all kind of the same. They differ a little bit in side effect profile, but in terms of efficacy, they're about the same. We generally stick to donepezil in most cases. It's a once-a-day drug. You start with 5 milligrams, you wait a month to see if they're tolerating it okay, and if there's no change, you can go up to 10 milligrams, and you kind of keep the patient at that dose until you see further decline, and then you have a discussion with families as to whether or not this needs to continue. Rivastigmine is also used in pills and patches. The reason it's available in a patch is because if you look at a side effect profile of rivastigmine oral administration, it's really poorly tolerated. You get a lot of cholinergic kinds of side effects. So for that reason, the patch was developed. the release is a little bit different from the patch, and so it's a better tolerated drug. So the patch is a daily patch. But the way these drugs work is by inhibiting the breakdown of acetylcholine. So they increase acetylcholine levels. So all the side effects from these drugs are going to be cholinergic in nature. Next slide. So what are those side effects? A lot of nausea, a lot of diarrhea, some vomiting, and weight loss. So you want to really make sure that patients with dementia don't lose weight. And so you want to be careful with that. That would be one reason to not go up to donepezil 10 milligrams and leave them at 5 if they're having those side effects. Bradycardia. We often see low pulse, and sometimes it's due to cholinesterase inhibitors alone. Sometimes it's due to a combination of, for example, being on a beta blocker and adding a cholinesterase inhibitor. So you do want to keep an eye on that pulse to make sure it's at least above 50. Dizziness and syncopal episodes are a possibility with these drugs, and that's the reason they're actually on the Beers criteria. So again, using it, increasing the doses gradually is sometimes a way to get rid of some of these concerns. These drugs can cause vivid dreams and somnolence. We generally dose them at night because they produce sedation during the day, and hopefully they remain a little bit more active during waking hours. Because they're cholinergic, you get frequency in urination, and in an older adult, that often will translate into incontinence because they can't make it to the bathroom on time. So sometimes what you see are these medication cascades where Aricept is started, they develop incontinence, and then they're put on an anticholinergic urinary antispasmodic, which sort of kills the whole point. Now you're giving a cholinergic drug with an anticholinergic drug to treat the side effects of it. So you want to be careful not to run into that problem. These drugs also cause drooling, runny nose, and watery eyes. And when I often talk to patients about this, they'll say, "Oh yeah, I've had that. I've been going and getting, chlorpheniramine or Benadryl, and it works great for my, runny nose." Again, Benadryl being anticholinergic, these drugs being cholinergic, the mechanisms of actions are butting heads, and they're really diminishing the effect of donepezil and creating more of an anticholinergic picture with more cognitive impairment. So be careful with that. And then headache is another side effect that you often see. Next slide. So some practical issues to consider. The benefits of cholinesterase inhibitors are small. So you really have to set expectations with your patients. What I usually tell my patients is when this drug is started, not to expect any change. And if you don't see any change, and if the patient remains stable in terms of their cognitive function, that kind of means the drug is working. You're not going to see an improvement in cognition usually, you're just going to see a stabilization of it. So there may be some improvement in independence or self-care, but there's not going to be this giant difference in overall cognition. And so the most you really can expect from it is a slower decline over the next 6 to 12 months. You definitely want to ask about side effects when you start these medications to make sure they're tolerated appropriately. And you at some point, you might want to have a discussion with families about when to stop this medication, because once the disease progresses, there may be less of a point of using these medications at all. And again, avoid agents with anticholinergic properties, especially when they're on the cholinesterase inhibitors. Next slide. The next option we have is mementine. And this is an NMDA receptor antagonist, and it appears to have a neuroprotective effect on the brain. In studies, again, it's not terribly effective. It is shown to decrease or increase an MMSE score by about 1 point. There's less evidence that it's effective in mild dementia. It's predominantly used in moderate to severe, and it's often used in combination with a cholinesterase inhibitor. It can be used, primarily it's used in Alzheimer's dementia, but there's some evidence that it can slow cognitive decline in vascular dementia as well. Next slide. Mementine is much better tolerated than cholinesterase inhibitors. Most patients tolerate it well. So the most common side effects are agitation, diarrhea, insomnia, dizziness, headaches, and maybe hallucinations, but they're fairly infrequent. Again, when you start this medicine, you want to do it slowly in a gradual fashion and with a slow titration, and then kind of monitor for those side effects. It does have to be renally adjusted in those patients with creatinine clearance less than 30. The maximum dose is 5 milligrams BID or 10 daily. The immediate release formulation is a BID formulation, but there's also an extended release formulation available, which now allows you to dose it once a day. So that's just something to keep in mind. So you start with 5 milligrams, usually at bedtime, and you go up by 5 every, roughly about every 2 weeks until you get to a 10 milligram BID kind of a dose. Next slide. So again, treat when reaching mild to moderate symptoms of Alzheimer's disease, usually used in combination with acetylcholine esterase inhibitors, and you kind of reevaluate for adverse drug reactions about every 2 to 4 weeks, and evaluate effectiveness is about every 6 months. Next slide. So there are a couple of trials that looked at combination therapy. Again, not terribly effective, but it does maybe offer some benefits in cognition and maybe some changes in ADL and other behaviors. Next slide. So the newest addition to the drug options we have is this new drug called aducanumab, which sort of made it on the market with a lot of controversy. It's basically the first drug that's been approved for this diagnosis since 2003. It went through an accelerated pathway, and the FDA advisory board committee that was looking at its approval actually voted against approving it, and the FDA went and approved it anyway. Organizations like AGS have voiced serious concerns about this medication, the safety of it. And CMS just came up with a coverage determinations for it, and it looks like they're only going to cover it for patients enrolled in clinical trials. So all of that is telling us there's really not enough data yet. We need to learn more about it. So I think there's a lot to be figured out in the next several years. One of the biggest drawbacks to this medication is it's extremely expensive. The projected annual cost is about $56,000. So it's unlikely that a lot of prescription plans will cover it. Next slide. So what is it? It's a monoclonal antibody which disrupts the production of amyloid beta plaques. It's an IV medication that's dosed every 4 weeks with a slow titration over 8 weeks to a target dose. You start with 1 milligram per kilogram and you end up with 10 milligrams per kilogram. There are no drug-drug interactions with the CYP450 enzymes, so and there are no pharmacodynamic interactions that we know about, and there's no renal or hepatic adjustment for this medication. The biggest issue with it is adverse reactions. What you get is amyloid-related imaging abnormalities, either edema or hemorrhages. And that happens in, depending on what kind of abnormality, but anywhere from 21 to 35% of patients will develop it. Clinical symptoms present in 24% of patients. And this is one of the reasons this drug is so expensive, because you have to continue to do imaging of the brain while they're receiving treatment. And if you look at the percentages of side effects, they're pretty significant. So that's the biggest disadvantage of this drug, and something that we need to look at a little bit more closely. Next slide. So in terms of clinical trials, we've got 3 trials basically. The first phase 1 clinical trial only had 165 patients. For these trials, all the patients had either mild cognitive, generally kind of mild cognitive impairment or prodromal kinds of symptoms. And in the small study of 165 patients, they did find that there were no amyloid beta plaques on PET scans after at 12 months of treatment at the highest target dose. So what they found out from this trial is that 31% of participants receiving the high dose discontinued due to adverse events. And the edema, the ARIA edema was more commonly seen in patients with ApoE who were ApoE carriers. Then there are two trials, phase 3 clinical trials, a total of about 3,000, a little bit over 3,000 patients. And here the results are quite mixed. So again, the patients they looked at had MCI or mild Alzheimer's disease with an MMSE score of greater than 24. 2/3 of the patients in both trials were ApoE carriers. And so the maximum dose they could achieve was 6 milligrams per kilogram, and the study length was about 78 weeks. One of the trials showed no statistical significance for primary outcomes in the high dose group, and actually some of them experienced a worsening in symptoms. And the second trial, Emerge, did show some improvement, which was statistically significant, but whether you can really translate into clinical significance is another issue. And 40% of those patients did not complete trial due to side effects. So this drug is at this point, we don't know enough about it, and it doesn't seem like it's a really great option for patients. It's not going to be covered by insurance. It's very expensive. The risk of side effects is pretty significant. So at this point, I think we just have to kind of wait and see. Next slide. So the basic principles of prescribing to your cognitively impaired patients is look at the med list often and simplify and consolidate meds as much as possible, because that'll really benefit the patient in the long run. Treat all the reversible medical conditions that can improve cognition. If you're going to dose a medication in these patients, do half of an average adult dose and titrate more slowly. Use the Beers criteria as a guide. There are lots of drugs on the Beers criteria that we use very successfully in patients, especially those who are cognitively impaired, but you have to understand why they're on the Beers criteria and figure out how to monitor for that adverse event in case it happens. And then the last thing you want to do is manage expectations of patients, family members, caregivers, to really explain how these drugs work and what limited efficacy they have and what really to expect from it. Sometimes you can get more from a good antidepressant that's working for a patient with cognitive impairment than some of the drugs like cholinesterase inhibitors or memantine. That's something to keep in mind. And I think that's it.
Thank you so much, Dr. Geriatrics. That was a wonderful didactic. I know we're running low on time. If you guys have any questions for Dr. Geriatrics, which you might, if you want to put them in the chat, we're more than welcome to answer them via the chat or after our case presentation. Again, thank you so much, Dr. Geriatrics. We are going to go ahead and move on into our case presentation presented by